Welcome to another Persiflager's podcast to review the infectious disease literature with commentary for the first 2 weeks of April 2007. For those who are sick of this intro, skip ahead to the next chapter. However, there are things I must say for CME reasons. First of all, of course, this is on iTunes. It's on iTunes. Please go to iTunes and write me a review. I want to thank the 3 people that have done this to date, but there must be at least 5 listeners. So I would hope that all 5 of you would go to iTunes and write me a review. This is brought to you by Puscast LLC, publisher of the Persiflager's annotated compendium of infectious disease facts, dogma, and opinion, your Uber hyperlinked electronic guide to infectious disease at Puscast.com. All the opinions are those of Mark Crislip and Puscast LLC, and not those of Legacy Health Systems, its employees, blah, blah, blah. This is CME accredited. Listen, take the online quiz, and get a half an hour of free CME. Thank you, Legacy Health Systems. Because it's CME accredited, I must mention that I have no conflicts of interest in giving this talk. This podcast is here to review the infectious disease literature with some snarky commentary. As a warning, it is not called Persiflagers for nothing. This podcast will probably contain snide comments, sarcastic asides, and short rants of a political or other nature. Don't complain I didn't warn you in advance. If you like this sort of nonsense, check out my Quackcast, also available on iTunes, a review of alternative medicine. And I would be curious, before we move on to the literature, am I doing this in a way y'all like it? Would you prefer more detail on individual studies or less detail? I would not mind feedback after 2 years of this nonsense as to length versus content. I think, however, again, this would be another 2-parter, as I think I have another 45 minutes of interesting medical literature. And now on to said literature. Always an ongoing topic in this podcast is the concept of use it and lose it. You use an antibiotic, you lose an antibiotic. There's a problem with viruses as well. And this article was in JAMA that looked at influenza B and whether or not it developed resistance to the neuraminidase inhibitors, i.e. oseltamivir. This was published out of Japan, and they looked at children who had influenza and then checked the sensitivity of their influenza B isolates after and before they received oseltamivir. They found rates in children who received oseltamivir of resistance at about 1.4%. They also found about a 1.7% resistance rates in patients who never received oseltamivir. They had a variety of mutations that caused this resistance to the medication. And the take-home message, I think, is that Darwin had it right. But often there are resistant subpopulations in organisms, and if you give antibiotics, you will select for that resistant subpopulation. That's certainly true in tuberculosis, and it would be apparently true in influenza type B as well. They also commented that many people who subsequently developed influenza B that was resistant to oseltamivir got it from people who had been on oseltamivir. So these resistant strains get spread from person to person as well. Now, I'm not saying don't use these drugs because they do work. As pointed out in a brief review in Clinics of Infectious Diseases, where they looked at patients who had leukemia and who got influenza, they found that 38% of their patients died if they did not get a neuraminidase inhibitor, where none of the patients who received the neuraminidase inhibitor died. So in a leukemia population, it was beneficial. This is in contrast to a similar article in the Clinics of Infectious Diseases that looked at the pulmonary complications of patients who were admitted with influenza. It is of interest that the use of antiretrovirals in this patient population was not associated with death rate, length of stay, or duration of hospitalization, and that their death rates, regardless of whether or not they received an antiviral agent, was about 6%. Now, the interesting thing in this study is those that got antivirals were much more likely to go on to require intubation. Is that because the antiviral agents made the patient sicker and had a higher need for intubation? No. In this case, it was that the patients who were sicker were more likely to get antiviral agents. But this brings up the perpetual point that association is not causality. Cats. the other white meat. There was a brief report that I mentioned many podcasts ago to suggest that cats were seropositive for avian influenza H5N1. The hypothesis being that cats eat birds so that cats get exposed, and that perhaps cats could form a bridge between birds and humans and be a vector for avian influenza. Well, unfortunately, this didn't pan out in a study that was looked at in Italy, where they collected cat serum samples from both pet cats and wild cats and found that none of them were carrying antibodies directed against the common influenza virus in Italy. Now, these are the human strains of influenza, but over a 6-year period, they could find no seropositive cats for influenza. Bummer. I was hoping this would be a reason to help eradicate cats from the United States, but I guess we'll just have to find another reason, like, I don't know, fun? Before I get an irate letter from a cat lover, just remember that cats kill hundreds of millions of wild birds every year in the United States alone, and they are a major source of predation on native wildlife. Cats, of course, not being native to the United States. The following contains no clinically relevant infectious disease material as applied to human beings, but it's so cool I have to mention it. There's a viral infection for which there's a new outbreak in Belgium. It affects animals, primarily sheep and cows, and it has the great name of blue tongue. It's spread by arthropods and is seen throughout the world, but it causes animals to have blue tongues. I just think that's a neat disease. I know that teenage boys are prone to getting blue. Well, never mind. Faget sign, F-A-G-E-T-S. Anybody know what that is? That's relative bradycardia for your temperature. For every degree your temp goes up, your pulse should go up about 10 degrees, roughly. Faget sign is a classic sign of certain infectious diseases, including typhoid fever, typhus, leptospirosis, psittacosis, babesiosis, and Legionnaire's disease. In emerging infectious diseases, they looked at the issue of relative bradycardia in patients with dengue. They had a comparison of patients with fevers, those that had dengue and those that did not. And for the same temperature, the mean heart rates were significantly lower in the dengue group, about 87 for those with dengue versus 104 for those without dengue. So you can add dengue to your list of diseases that may cause relative bradycardia for the fever. Dengue should be seen in the United States in the next 20 years. It's one of the diseases that's expected to be seen as the climate changes. An article published in the journal Homeopathy looked at the treatment of dengue symptoms in Honduras using solutions that were diluted to 10 to the minus 24. I know this is not my quackcast, and I know that there's nothing stupider on the entire planet than homeopathy, but it didn't do diddly. And I have to quote a paragraph from the discussion that shows how deluded homeopathic physicians are. Despite the misdiagnosis from a homeopathic standpoint, these patients with pain and fever should theoretically, what theory? Homeopathy doesn't work, respond to this combination of remedies, well known in the homeopathic, quote, literature, unquote, for their use in flu-like symptoms. The fact that they did not is troubling, suggesting that further therapies of this combination may not be indicated. Perhaps it didn't work as homeopathy is stupid. Jeez! It has zero physical and biological plausibility. But Dr. Jacobs, who's from the University of Washington, loves to inflict nonsense on people in South America. She's also inflicted homeopathy on the poor who have diarrhea in that part of the world. This is one of the amazingly stupid articles to get published in the medical literature, though the journal Homeopathy is barely the medical literature. As polio hopefully disappears from the world, the use of the oral live polio virus will probably disappear, and in its place people will be using the inactivated polio vaccine. Another shot and another opportunity to place tracking devices in the population. But does it work? Well, there was a study that was done in Cuba where they tested the inactivated vaccine in children, and found excellent seroconversion rates. Then they challenged them with the oral poliovirus and found a 3-log decrease in viral titers compared to the controls who did not receive the inactivated vaccine. So they estimate that the efficacy rate of the killed vaccine is greater than 90%. You got your parvovirus B19, called B19 because it was in row B, column 19. You also got your parvovirus B52, which primarily infects rock lobsters. But in the family of Parvoviridae, there's also the human bocavirus, BOCA. Now, this virus has only been described since about 2005 as a human pathogen. I mentioned it in prior podcasts. I mention it even though it primarily infects children because it is a new agent. In most studies, it causes a respiratory infection of children and accounts for about 7 to 10% of outpatient respiratory infections in the world. But it also, in a study published in EID, causes diarrhea, and they could isolate it from the gastrointestinal tract in almost 10% of children in Spain who presented with the Hershey squirts. So the human bocavirus, a cause of respiratory and gastroenteritis in children. Today is April 15th, and we're allegedly going into springtime. Weather wouldn't support that currently. But file this away for next winter. Turns out that about 10% of respiratory infections in the elderly in this hospital in New York are due to influenza A. Another 9% are due to respiratory syncytial virus, i.e. RSV. Can you tell the difference clinically between RSV and influenza? The answer is probably not. That the clinical findings are not that sensitive or specific for differentiating between the two, but there are a couple things that may give you a hint. One is nasal congestion. Then what have RSV are more likely to have nasal congestion. They're more likely to have wheezing, and they're not going to be quite as toxic as evidenced by fever. So it tends to present with more of an upper respiratory stuffy wheezy syndrome, and now I sound like a NyQuil commercial. But it lacks sensitivity and specificity, so you should probably send off appropriate cultures for each virus if you should suspect them. I think the key thing here is that RSV is probably more common than we anticipate, and we could look for it more. That we, of course, means me. I got my invitation in the mail this week to join AARP, so I'm officially old. In dog years this month, I become 350, which is pretty good. So I get to be crotchety about the old days. I remember back in the day when we saw patients with CMV retinitis on HIV disease, which I don't think I've seen this century. I mean, Hart has been that impressive at making CMV retinitis disappear. One of the problems, however, with treatment of CMV retinitis is the development of resistance to the primary therapy. This was a nice study that will hopefully continue to be of historical interest, where they look prospectively at patients with CMV retinitis over a decade. They were treated with ganciclovir, and they looked for the development of resistance. Take-home message as follows. 1. Resistance occurs. At 2 years, the incidence is about 28% in the old days and about 9% in the new days. What are the new days? Patients after 1996 when we have Hart. So the use of highly active antiretroviral therapy has decreased markedly the incidence of CMV resistance to ganciclovir. Also of interest that virtually everybody who developed resistance to ganciclovir had CD4 counts less than 50. So, with the exception of Tony Bennett, who I believe left his heart in San Francisco, the current therapeutic modalities we have to treat HIV are, amongst other things, decreasing the incidence of resistance of CMV to ganciclovir, which still is 9% after 2 years, but is much less than it used to be. So yet another benefit to Hart. I think I'm going to go listen to Dreamboat Annie right now. HIV, of course, is spread a variety of ways. But when is it mostly spread? There's been modeling to suggest that early in the disease is one of the most important times for the spread of HIV disease. This turns out in a study in Quebec, or should I say Quebec, to be true. They did genetic analysis of all the HIV and the reported partners of patients with HIV, and looking carefully at the genetics of the HIV virus, they found that half of the spread of disease was in the early seroconversion / early part of HIV illness. That's the first 6 months. So in Canada, and this has been supported in studies in Uganda, about half of HIV is spread in the first 6 months of a patient's infection. This epidemiology of HIV spread is important in trying to determine optimal ways to prevent spread of disease. Unfortunately, the first 6 months is an uncommon time, at least in my practice, to find someone who's HIV positive, given that many people don't present until they have at least some symptoms of prolonged HIV disease. And the initial infection of fevers, adenopathy, sore throat, and a rash is not specific enough that people often think of HIV. And since it's in young people with a, quote, viral syndrome, they may not get a good history taken as to risks for HIV. Hopefully, universal testing will help ameliorate this particular problem. Now we go from viruses to bacteria and to my all-time favorite, MRSA. MRSA has been reported to be spread from animals to humans. Specifically, dogs, horses, and pigs have been reported to transmit MRSA to humans. Now in Emerging Infectious Diseases is a case report of someone who got MRSA from a cow that had an MRSA mastitis. So we can add another animal to the list of potential sources for MRSA. This reminds me of a joke. If you would like to hear my cow joke, send me an email. Now, you don't have cows in the hospital. I'll pause here where you can make up your own joke. Now, the number one source of MRSA is your hands. And I know that you are a compulsive hand washer and a compulsive adherent to good hand hygiene, aren't you? Aren't you? There are other things that have been documented to carry infectious diseases in the hospital. Ties, which is why I no longer wear one. Beepers, which unfortunately I still have to wear. But there was an interesting study in Japan that looked at the transmission of MRSA in hospital wards. And they found that it was associated with the neurology ward and specifically with the face. So that patients who were having cranial nerves tested would have their face touched, and then subsequently the MRSA that they carried would be spread throughout the hospital. So they documented in their neurology ward that touching the patient's face for the testing of cranial nerves was associated with the spread of MRSA. So don't touch the patient's face, or especially if they've been using their face for milking a cow. Pause here to reflect on the spread of infectious diseases. It is mind-boggling how quickly they can spread across the world. Take, for example, MRSA. Now, MRSA has an important virulence factor, the penton-valentine leukocidin. And although there was a recent article in CID using a knockout of the gene to suggest this was not an important virulence factor, which I don't believe given the overall data, it certainly is a marker for the current MRSA. Most of the strains of community-acquired MRSA have a different methicillin resistance gene, the MEC4 gene, and most carry the penton-valentine leukocidin. As pointed out in EID this month, it has spread across the world with remarkable speed. It was virtually unheard of in 2003, and now it is in virtually all the continents, including the United States, South America, and Europe. In 4 years, this organism has spread across the world. I assume primarily on the udders of cows, and that it is these herds of mastitis bovines that have gotten on jet planes and spread this MRSA across the country. It does give one pause, however, when one contemplates how quickly virulent organisms can sweep across the world. The MMWR has a report of 10 cases of community-acquired MRSA pneumonia, of whom 6 patients died very rapidly in 3.5 days after presentation. They all had the Panton-Valentine leukocidin, and they all developed the community-acquired Staph aureus pneumonia after influenza. Now, we have dodged this bullet for several years, but I still worry. If we do get avian influenza jumping into human beings and we have a massive amount of unvaccinated people, combined with the high incidence of MRSA in the community, that's a setup for a lot of post-influenza pneumonias and death. I've seen one post-influenza MRSA pneumonia who died with incredible rapidity from a diffuse hemorrhagic pneumonia. And that fate may be in store for a lot more of us if we get the bad confluence of an influenza outbreak in an unvaccinated population combined with the high incidence of MRSA in the community. Time to buy your shares in the coffin-making industry. I mentioned in a prior podcast there's been some case reports of IVIG being successful in the treatment of C. difficile diarrhea. In this study in the American Journal of Infection Control, they did an analysis of 79 patients who had C. difficile. Of these, 18 patients had IVIG for the treatment of their severe C. difficile diarrhea. And unfortunately, it did nothing. It did not decrease the rates of colectomy or severity of disease. Although it was small numbers of patients, it is more than has been seen in prior studies. And based on this, I would be disinclined to recommend IVIG for severe C. difficile. See my prior podcast on rifaximin and C. difficile. What is the best treatment for C. difficile initially? Well, here's another log on the fire of debate as to whether it should be vancomycin or metronidazole. This was a study that was published in abstract form at the European Congress of Clinical Microbiology and Infectious Diseases and reported in Medscape. They looked back at a database of patients who had the ICD-9 code of 008.45. That is, for those of you not in the know, the diagnosis for C. difficile. And this was between January 2004 and June 2005. They found that patients who had treatment with metronidazole had longer hospital stays, higher death rates, and higher costs. So that in this study, which was retrospective in a database, suggested that when they looked at large numbers of patients, that metronidazole was inferior to vancomycin for all the clinical parameters one would follow for C. difficile diarrhea. So the real question is whether or not the initial therapy for C. diff should be vancomycin or metronidazole. Currently, the recommendations for vancomycin are for treatment failure, severe disease, usually as manifest with a white count greater than 20,000 or signs of toxic megacolon, and disease recurrence. So what's the best initial therapy for C. difficile? For mild disease, I'm still going with Flagyl up front, but my threshold for beginning oral vancomycin is dropping. Unfortunately, that's going to help drive vancomycin resistance in the enterococcus, which in turn will allow those genes to have a higher probability of jumping into Staph aureus, so that soon we will have Staph aureus that are resistant not only to methicillin, but vancomycin. Daptomycin and linezolid resistance is a slam dunk for that organism, and I'm predicting that when I retire in 15 years, that we will have a problem with Staph aureus, or should it be Staph aureae, that we cannot kill. The true. Vibrio infections have increased dramatically in the United States over the last couple of years, according to the MMWR of April 13th. Vibrio infections have increased 78%, whereas the infections due to Cryptosporidium, Salmonella, and E. coli OH157 has not increased. I find this fascinating in that if you hearken back I reported an article in the New England Journal of Medicine many podcasts ago where they were seeing Vibrio infections in oysters from Alaska. This was because for the first time ever, Vibrio were in water warm enough where they could contaminate the oysters from Alaska. One would wonder, though not mentioned in this article, if this is yet another manifestation of climate change and the increase in infectious diseases we are seeing and will see as a result. Consider me the Al Gore of infectious disease and climate change. I look forward to collecting my Oscar for podcasting, i.e. my Puscast, for my work in the area of climate change and infectious diseases. Thank you. Thank you very much. The journal Gut published an article out of Italy that looked at 1 week versus 2 weeks of omeprazole, amoxicillin, and clarithromycin for the treatment of Helicobacter pylori, and they found that both groups had an 80% cure rate. So 1 week of amoxicillin, clarithromycin, and omeprazole was sufficient to cure H. pylori. Unfortunately, the efficacy of therapy for H. pylori has been drifting down, and this is probably due to clarithromycin resistance, which is increasing slowly but surely in Helicobacter across the world due to all the other inadvertent or advertent clarithromycin usage for respiratory tract infections. Some studies have shown that if you have had clarithromycin within the last year, you had a significant chance of a clarithromycin-resistant Helicobacter pylori. But 1 week should suffice if you are going to treat this, especially if they're Italians. Some have suggested that anaerobic bacteremia can be predictable if patients have certain underlying diseases such as gastrointestinal sources, and that if patients have those sources, then that's the time you should do anaerobic blood cultures. However, the Mayo Clinic has shown a marked increase in their anaerobic positive blood cultures, and they were in patients who did not have the classic risk factors, i.e. a GU source or a GI source, and subsequently they suggest that perhaps anaerobic blood culture should be done more frequently than in the past. The most common organism that they grew was still Bacteroides, followed by Clostridia and Peptostreptococcus. The recommendations are that perhaps anaerobic culture should be done more routinely than otherwise, and that, especially in patients with a variety of malignancies, having an unexpected anaerobically positive blood culture is not that uncommon. Well, I'm at 27 minutes and 53 seconds, and GarageBand with which I do my recording gets wonky after about 35 minutes of recording. So I'm going to end Part A and move on to Part 2, which will cover mycobacteria, fungi, and some various antibiotic issues. This has been Part 1, or Part A, or Part III, of the April 1 through 15 Persiflager's Infectious Disease podcast. I again ask that you rate me up on iTunes, but it would also be good to send me an email and let me know if you like the format of the podcast. I notice they're getting longer, but I find more and more stuff that I think is of interest. This is CME accredited. Take the online quiz and get a half an hour of free CME thanks to Legacy Health Systems. This is brought to you by Pusware LLC, the publisher of the Persiflager's annotated compendium of infectious disease facts, dogma, and opinion, your uber hyperlinked electronic guide to infectious diseases at pusware.com. If you like this, check out my Quackcast, an analysis of alternative and complementary medicine, or as I like to refer to it, BS. Bandwidth ain't free, so feel free to purchase the compendium and support this podcast. If you're not going to pay for it, at least write me a good review, huh? Jeez. It's copyright under the Creative Commons license. The music is by my 12-year-old son improvising on the guitar. As usual, thank you for this most interesting consultation, allowing me to participate in the care of this most difficult and challenging case. I will continue to follow along with you. Thank you. In dictation. Goodbye, and I'll see you at Part 2.